This has been an incredible day. Thank you, Seth, and panelists. And I'm going to try to make this brief. I want to tell you kind of what comes next and what we're going to do with all of this day, and then maybe have a brief call out in that context. So we're going to put together a summary of the workshop and present it to the Assistant Secretary. Probably it'll take about 3 to 4 months. It gets sent to review. There's some, this is, I think, the important point for this last session, is that these proceedings, the proceedings that get sent on, can't expand beyond anything that's said in the room. So what I would like to do for this last very brief session is that, because we've covered a lot and we've covered it multiple times. So I could spend a lot of time summarizing, but it's going to be all in there. I'm going to spend a brief time summarizing. But what I want you all to think about is there's something that we didn't cover today that we really want to make sure is on record. Okay, so I'm going to give you an opportunity for that. And I think that's my main comment. So here are my very tweetable, not really tweetable because they're not even that, unique here, but let me just summarize in very short statements because I thought that part with the short statements was good. There's underinvestment in social needs. I think we all can agree on that. As an economist, it's clear just from the market, it's just not there are a lot of places where the market doesn't function right. The wrong pocket problem, which is, investors can't capture the returns on their own investments. That's a problem for getting enough investment. Time horizon, so there's all these externalities which lead to underinvestment. And there are a lot of these investments are public goods, so it's collective action is needed. So just by kind of the theoretical framework there's underinvestment. Value-based payment is a wonderful way to try to address some of the many ways there's underinvestment. And I think the great tweetable line on that is economic incentives work. So we should embrace that. And the third one is more research is needed. Don't tweet that because that's what everybody says. And I say that in a very self-interested way. But I think there's an opportunity to make some choices or to think about infrastructure that can lead to more rigorous evidence-based research. And there's so many great ideas that came up during the day around evidence standards, getting more data, administrative data, like in the electronic age, and making linkages and addressing privacy issues and creating standards and all that kind of stuff, I think would really raise the bar there. But there were just so many ideas in that space. I won't do justice by summarizing them all. It's an inadequate summary from such a wonderful, rich day. But the purpose here in this very last few minutes is if someone says, gee, we did not talk about X, and I want to get it on the record. So I'm going to give folks an opportunity, and I see a hand up there and a couple of people. We'll start with the mics. Go to the mics, Sarah.
Hi there, thank you. Thank you for the opportunity for the one last thing, because I have something that kind of fits everywhere and nowhere, which is that I'm with the American College of Preventive Medicine. And in self-interest, when I listen to the discussion today, I feel like there are a lot of places where preventive medicine specialists fit in as the bridge between clinical care and community needs, as the folks who can do translation back and forth from lessons learned to academic journals such as ours, the American Journal of Preventive Medicine, or from those journals to communities to learn how they might work with people better. And the sort of open question perhaps for us when we're looking at infrastructure and return on investment is, what investment are we making in training for people who have this kind of cross between medical training and population health, public health. We have, the way that it's done is through residencies. And so there are a limited number of residencies that are trained. And if a young physician chooses to go with preventive medicine, their choice is influenced by the fact that preventive medicine is likely to pay a lot less of their medical school debt than another specialty? And how do we provide incentives for young physicians to, or older ones, many of ours have gone back after practicing for a while because they see the need to look across a population. So training, incentives, raising the field of preventive medicine as the folks who can help us with some of these connections we need to build. Thank you.
Thank you.
I appreciate the invitation to add 2 sentences that someone may take some notice of. In the last session, as we were talking about the research needing done, it's clear that we, in some ways, have hamstrung our opportunities to improve by defining rigor in a certain way that requires the kind of interventions that were very useful in determining the genomes of peas by a Catholic priest some years ago. But there are other methods that we have more or less ruled out that we might want to start using and that are commonly used in Europe and England. Realist evaluation, Shewhart statistics. These are not just pre-post. These are assuming that you're working with a setting in which the mechanisms and the context really matter and their intervention really matters. So rather than thinking that you can randomize Pittsburgh, you work with Pittsburgh and who they happen to have as leadership. But you look at something that you can follow over time and understand the variation and where the midline performance is and work to reduce variation and improve the midline performance. And it seems to be very fertile and applicable to a number of our issues, but we rule it out because it's not a randomized controlled trial or a lookalike to an RCT. And RCTs are good for isolating the likely causation, not the for sure causation. But if you're willing to rely upon wisdom to figure out the causation, and your main impetus is to actually make change, then these may be some methods that we should explore and begin to figure out where in the pantheon of research we expect to use these more flexible methods. We need to be able to answer questions faced by our body politic in efficient ways. And it is very inefficient in general to insist upon a huge RCT rather than to answer the question good enough to get to tomorrow.
Thank you. We'll move on to the next one. So I will try to make these really brief if we want to get a couple more people to give a voice.
Thank you. I believe my comments will have some kind of concordance with yours. I was wondering if we should think about addressing social determinants of health also with some broader literature in mind. So when we look at benefits of systems and structures in place, we think a little bit about density of primary care providers in different areas, and then the effects that has on the population health. It lowers mortality, it reduces cost. And should we think more broadly about some of those systems-based interventions that we don't traditionally think of as social determinants of health interventions as things we should push forth with policy, because there is reasonable evidence around it now. We know about some of the benefits, and we know that right now training incentives are not aligned with being able to really create these changes within systems that we know will improve health.
Thank you. I think that aligns with some of the other things that people have talked about. That's great.
I think following on a little bit to Dr. Lin, there are also, in addition to the interventions that we've heard about today, which all seem to be kind of one marginal change, either it's food or it's housing or it's legal, but there are also interventions that do exist that have been designed in a very comprehensive way. So I'm thinking the Magnolia Place community in Los Angeles, which is multiple sectors, multiple types of social needs, all kind of housed together under one roof, where with warm handoffs between different social service and medical professionals to kind of address this whole person concept. So I think there are opportunities for research, even sort of in a relatively controlled way, because this is confined to one geographic area in Los Angeles, and there are opportunities for comparisons I think that we could make. But then I think stepping back from that as well, I think there's also need to think about some of the policy interventions, legal changes which are designed to tackle social determinants. I think the Trust for America's Health publication that what we had a picture of earlier did a very nice job of laying out not just the sort of midstream interventions that we're talking about today, but the more upstream things like changes in policy that improve affordability in entire markets. So I think those are also the kind of things that we need to think about in addition to these RCT level individual interventions.
Thank you.
Good afternoon, Uche Uchendu, Health Management Associates. I just wanted to elevate health equity. I had a conversation sidebar with John during one of the breaks, and he did agree. I'm glad that Cyrene pointed out some elements of health equity, but I think there needs to be a little more, because we assume that social need and social issues may take care of health equity issues, but they don't usually. Proxy of zip code for race or proxy of this for that. I won't get into the details or to the level that we adjust for confounding factors and lose the essence. So I think it's important to bring health equity, health disparities issues, race, ethnicity, gender, and those elements, including geography, rural, urban. And in my role as Chief Health Equity Officer, one of the things we insisted upon in defining equity elements was that it wasn't about rural being disadvantaged. It's that there are urban challenges, there are rural challenges. So being able to look at each of those as elements and superimpose that in the decisions that are being made. And I'll echo the conversation about not looking for randomized control trials only. During my tenure as well, we did pull out quality improvement projects for which I wrote the IRB's boards to say, this is not research, it's quality improvement intended to advise policy and so on. There are those algorithms that you can use to be able to still do what is necessary. While the research is also important, I think they don't have to be mutually exclusive. Thank you.
Thank you. Before closing, I'd like to give my co-planners an opportunity to have any final thoughts. You got anything more to add, John, Seth? And I guess in closing, the person that I really want to thank is Rose Martinez, who really was the driver of putting all of this together, and her partner in crime, Anna in the back. I want to thank the two of you for your great work and putting this panel together. Thank you very much. And thank you all for a really extraordinary day, and safe travels. Anything else I need to add or anything? Okay, well, thank you very much. Have a good evening, everybody.